The Graziadillo School of Business and Management at Pepperdine University proudly presents the Dean's Executive Leadership Series. This podcast invites top business practitioners and thought leaders to share their view on the real world of business.
I just have one question for Leslie, and then I want to open the floor because I know so many of you have questions you would like to ask related to some of the things that Leslie mentioned in her remarks, but probably about other things as well. But the one question I wanted to ask you, you were talking at the end of your remarks about being willing to partner with anybody and work with anybody. So I would just say, when you look across this room, we're sort of average, everyday citizens and customers of Anthem Blue Cross or other insurers. What can we do as consumers of healthcare, as sort of average citizens in California or other places, to be a part of the solution to help bring this to some kind of resolution that makes sense and actually helps solve the problems?
I think there are a number of things that you can do, and you can think about it from a university perspective, and you can think of it from just a purely individual perspective. I think each of us could play a role in reframing the debate. And I think that's the single most important thing that we can do. It reminds me of sort of look over here, this is the issue. So we don't have to get at the real issues in the healthcare reform debate, and we need to. So I think talking with friends and family, talking in your communities, with legislators, with regulators, not buying into sort of the hype, and insisting of them and insisting of me that we get down to the real discussion and the real solutions. I think that's the most important thing you can do. I also, after my testimony, and that was one of the hardest days of my life, and I went to the airport and was sitting there, and I was kind of tired, as you might imagine. And, they had a panel of Anthem consumers who had come up just before me and at the hearing hall. And one of the women on that panel, who I'd noticed, I recognized her because I saw her with a microphone up to her mouth. And she came up to me in the airport after I spoke, and she said, I'm so sorry what you had to go through. I, for the first time, having heard you speak, for the first time, I have faith that we can actually solve the healthcare crisis. And she said, the only thing I was disappointed about in your remarks is you didn't ask for consumers' help. And I was struck because I hadn't. I talked about everybody else that I thought of as stakeholder, and I talked about patients, but I hadn't talked about people as consumers of insurance and care. So I've learned an important lesson through her words, and I intend to include consumers in helping us think about this. And so in that respect, just as individuals, if we ask for help, please come and share your thoughts and your experiences and your advice about how the healthcare system has served or not served you.
Wonderful. Open it to the audience. Who would like to kick us off this evening? Yes, sir.
This is just I'm a policyholder of Blue Cross Anthem, and I also have cancer, which is kind of like, my question is, I was listening to a program yesterday, and somebody mentioned in California, they have cancer insurance, and it's being somehow created in Sacramento or something like it. But it's the first time I've ever heard of it, and they said that nobody likes it because it's too expensive. But I was just thinking to myself, well, I've never even been told about it, and even the hospital that I go to, they never mentioned it. Nobody's ever mentioned it to me until I heard this little blurb, and I go, well, this is interesting. I said, now we're going to hear from the president of the company, and maybe she can. I mean, it's kind of a weird, maybe it's a weird question, but.
No, I mean, it's a legitimate question about what are the products that are out there and how do you learn about them in the system. So, he had a particular question about cancer policies that are there. And I actually know we have them at Pepperdine that are available to purchase as a supplemental to our insurance. So it's a great question.
It's a great question. I actually don't know the answer, but I have a man on my team who does, who is a graduate of Pepperdine. So you can.
Sure. Anthem Blue Cross does not offer what they're typically called are critical illness policies. So Anthem Blue Cross doesn't offer them, and a lot of the major insurance companies in California and elsewhere don't. Where you find critical illness policies are typically through, and I don't know that they do, but like your Aflacs and Colonials and Transamericas. And what they'll do is they'll provide critical illness or accident coverage, and obviously, it's much like life insurance. You're basically paying a premium, and there's a risk associated with it that some subset of their population will develop whatever that condition is that they're paying the policy for. And if you happen to get cancer, then that triggers the policy and you get a payout of some sort. But we don't offer that coverage, and many of our competitors don't either.
Thanks, Mark. Very helpful. Let me go back here and then I'll come back.
I know this topic can lead to a long discussion, but I had an interest in what role you thought alternate dispute resolution, such as arbitration, could have on tort reform, and what your thoughts were, very generally.
The question was, what role might alternative dispute resolution have in the world of tort reform? I am such a proponent of alternative dispute resolution in any of its form, be it arbitration, be it mediation, be it just sitting down and engaging in what I would call an interest-based problem-solving process. I think it has an enormous role. I think people are afraid of arbitration because they feel that it will narrow their rights, and I think we have to protect against having that happen. But the opportunity to resolve disputes on a more amicable basis, to figure out what went wrong, to make it so that people and organizations aren't afraid to say they're sorry for having made a mistake. I think it's one of the worst problems in the industry, is in any industry. Fear of litigation and fear of kind of the punitive damages that flow from that make it almost impossible for people who are harmed and people who have in one way or another caused harm to sit down and figure out what happened and how can we make sure it never happens again. And that's the debate, that's the inquiry we should be having. So I think there's an enormous role to play. I think you're right. I mean, it is the stuff that books are written, big books and lots of books are written about, but I think it's an important part of the debate.
Question here, and then we'll go to Edna.
I keep hearing that Medicare doesn't pay its way. How far below, say, what you would pay a hospital is Medicare?
Well,
80%? Is it?
I think that in virtually any hospital, any medical group, any situation, there would be a different number, but the numbers that are most often quoted by hospitals and medical groups are probably in the 20 or 30% range, that there's that much of a cost shift. Yeah.
Edna.
You talked about doctors practicing.
Speak up just a little bit so we can make sure.
You talked about doctors practicing defensive medicine. Do you think the answer to that is a cap on malpractice, or what are your other ideas about that?
The question was about doctors practicing defensive medicine, and what might I think would the cap be? Would the answer be? Would it be a cap on malpractice liability? Many states have caps on malpractice liability. There are all different variations on that theme. I actually think the question that was asked a moment ago is probably a bigger part of the solution. It is finding a way to have conversation and solution around what are the best courses of treatment, the most successful courses of treatment, the highest value courses of treatment, so that you could create, there's a whole body of work, it's called comparative effectiveness, where they look at these kinds of issues and try and figure out through medical evidence what are likely to be the most successful solutions. And I think if we could somehow come to some common understanding about that, then people probably would not be as inclined to feel a need to go to what is called defensive medicine, to doing all other kinds of tests and all other kinds of courses of treatment, because we would be able to come together in a more rational way to think about sort of generally accepted practices of medicine or successful practices.
I'm one of the possibly unusual people here, perhaps than you. I'm one of the individual policy holders that has had my policy since 1992 because I believed very strongly in the insurance system, and it was not for profit at the time. And as people may well know, the financing for Blue Cross Anthem and WellPoint originated in our policies, people like me. So we're the original policy holders. And so our premiums, 25%, were taken and used to cross state lines to buy other state not-for-profits. But now we are confined to only buy our health insurance in the state of California. So how can our money go across state lines and purchase other systems, but yet we can't have a competitive ability to even find a better plan for ourselves? By the way, I believe strongly our healthcare system is wonderful, and I really believe in the insurance system. I don't believe that we should allow our healthcare to be entrusted to a bureaucratic thing. You are committed to healthcare, and thank you very much for that.
Thank you.
But my question is sincere, and then how did Blue Cross Anthem become the villain in this relative to this, what's going on in Washington?
There are a couple of levels to your question, and I'll answer as best I can. And if I miss something, please tell me, and I'll get back to it. The issue you raise around premium dollars going across state lines, and that was a big part of the debate, of the testimony at the assembly. You know, we are owned by a company that is headquartered in Indiana, WellPoint. Anthem Blue Cross here in California is owned by them. They are our parent company. As in any other industry, subsidiaries of a parent company dividend dollars back to that company. The dividended dollars, I don't think of them as just dollars going out of state. What I see is a parent company that provides coverage to 35 million Americans across the country. And that company has to invest in technology, in systems, in processes, in staffing development, in figuring out what are the breakthrough safety solutions. And if we did that in each state separately, we would never come up with the kinds of solutions that are enabled by our bringing dollars together, trying to figure out solutions, the support that I get to provide coverage and solutions to the part of the business I run is 4 million members in the state, but we have 8 million members in the state. I'd never be able to do that on just my piece of your premium here in California. So I think the debate is, it's taken on sort of a fever pitch about going over state lines, but I think the people I work with and live with every day would say that there is great value to us and to our members in that. In terms of how Anthem Blue Cross became the villain in the debate, it was a debate that needed a villain. There had been sort of a quiet in the storm, in the debate, and it was looking like healthcare reform was not going to get legs and was not going to pass. And I think that it was important to resurrect the debate, to have someone or something that ignited passions. And I think how it came to be Anthem Blue Cross was that we had poor timing in announcing rate increases.
Unfortunately, though, it looks like it was explicit. It looks like you had a premeditated reason to do it, that you might get a contract down the line from the government. That's what it looks like. And people whom I know, they say, would you ask that question? Because we're concerned. That's what it looked like. And we're the Blue Cross people.
Yeah. I'm sorry if it surprises me to hear that. I wouldn't have thought of it. I couldn't have imagined that. And I can only speak from my knowledge and experience. And my knowledge and my experience and my wish is that we hadn't. So the idea that we would do it deliberately for some reason, it's just absolutely the furthest thing from my mind and the mind of anybody that I work with.
Scott, you had your hand up.
Well, I was just wondering if any thought's been given to outcome-based medicine. It seems like I always try and find in situations what motivates somebody. What is the motivation to keep someone alive? Is it the dollars that they earn from it? Because maybe that's backwards. Maybe they should make more money if they keep them alive. But if they die, they don't get as much. I mean, I don't know. It's kind of absurd, but.
But it's Scott. He's an old friend. Scott and I used to work together. I don't know if you could hear his question. It had to do with whether or not there was wisdom and reason to think about reimbursement differently and think about reimbursement based on outcomes. Absolutely there is. It's a huge part of what we could tackle and what we need to tackle to think about reform of reimbursement. And the interesting thing is that medical groups and hospitals are ready for it as well. We have a number of efforts underway right now looking at how you think about episodes of care, how you think about rewarding outcomes. One of the things I didn't mention but I had in my notes is thinking about even just how we structure coverage differently. I mean, wouldn't it be interesting and important if we created sort of a basic health insurance policy that rewarded prevention? You think about the crisis in American healthcare right now. You think about obesity. You think about lifestyle habits. And we always, as a people, we tend to think about what are the sticks that we can employ to stop people from doing things. But what if we created an insurance policy that went across the state, that was available to everybody, that was affordable, maybe didn't have everybody's favorite mandate in it, but it had 100% preventive care, and it gave rewards to people for healthy lifestyle, for engaging in diet and exercise and those sorts of things. It's just reframing the question a little bit, but that reframing is so important. Nobody wants to be penalized. Nobody wants that, and it causes people to stand up and be angry and resist. But if you reframe it, you get to the same issue, and you get to it in a way that is so positive. So, Scott, it's a terrific question, and I'd actually love to work with you on it. We have so many people who are trying to think this through, and I think we could use a few more really good heads on it.
I have about 100 questions, but I won't bore the audience.
Pick one for now.
I'll pick the one. Your program to improve hospital safety. That seems like something that could be easily scaled across the country. So do that?
I'm sorry, did I interrupt you?
No.
The question was our collaborative for patient safety. It's called Patient Safety First, a California Partnership for Health. The question was, it seems like it could be scalable or leverageable across the country. Have we thought of that? Absolutely. It is so scalable. What I wanted to do with it, and I partnered with the hospital association CEOs up and down the state, what we want to do is launch it across California. We've picked as our initial areas of focus just 3 areas. One is eliminating sepsis. The second is eliminating certain, they're called central bloodline infections, infections associated with certain procedures in hospitals. And the third is a slight variation on the theme. And in that we partner with all of the hospitals, but we've also partnered with the March of Dimes. And this one is about providing education and communication to mothers and families and physicians in informing about the risks of making voluntary decisions, elective decisions to have early delivery, to induce labor before the full 39-week period of gestation. The risks of those decisions for convenience of the mom or availability of the doctor or for comfort. If it's medically necessary to have something like that early, that's perfect, that's fine. But so many people schedule around matters of personal preference or convenience. The dollars at risk, the safety of the children, and the lifetime of illnesses that result from that decision are, it's extraordinary. We have a bit of a debate in our company about just how much money is at issue over those decisions, but it is many tens of millions of dollars just in our own patient population. So if you take it and scale it across the country, I mean, if you could take just that and marry the March of Dimes and drive that change across the country, we would have such dramatic improvement in health and such dramatic reduction in cost. So I'm all for it. I'll leverage this anywhere that we can. What I want to do is take this pilot in a way that I'm sure we can make it successful, get the kinks out, and then replicate it across our organization and share it. I think all the health plans should join in. I don't view this as a proprietary thing. I just think it's a responsibility that we have to improve care.
Got 2 questions here. First, and then we'll go to that row.
Could you go back to preventative care and talk to any initiatives that Anthem Blue Cross currently has? And you also mentioned something about rewards. I thought that was a fantastic idea, but how do you measure? What are the metrics for that?
You know, I can talk with you about it at a very high level. I think the point I really want to make is everybody is doing work around prevention, having on-site wellness programs, doing work. We work with individual members and we work with employer groups around exercise and fitness programs, around healthy lifestyle choices. We partner, one of the things that Tim Jordan on my team and I have been working on is working with the major athletic teams around California and getting them to come to the schools with us. We work with the Lakers and the Dodgers. We are the primary funders of the Governor's Council on Physical Fitness so that we can go out to the schools across the state, and we do it ourselves, but they don't want to see a bunch of insurance executives. So we bring people like Lisa Leslie and Lila Ali, people who kids look up to, and we have them come into the schools and talk about fitness, nutrition, teach them ball handling skills, and it's a really fun kind of dynamic thing. The point is it is an area of such great opportunity, and it's about instilling the practices early on in kids' lives. So that they're practices and habits that they hold for life. I think that's a huge part of it, but it also can come in the form of designing products. It can come in the form of having healthcare coaches, which we have, people who see an issue or work with a particular population. I think there are any number of ways to get at it. What I believe is necessary is to bring people together who know a lot more about it than I do, clinicians and dietitians and exercise physiologists, and figure out what would, not just what's the window dressing, not just what's the sizzle part of this, but what's the steak part of it, and where do we really expect to see results, and then drive that. You had a second part to your question, and I think I've missed it.
The metrics, how would you measure if somebody is, exercising? I mean, blood work could be misleading sometimes, for example.
Yeah, actually, I'm not trying to pass this back to the school, but that's an area where we really could use help, thinking about what the design of a program would be, what the appropriate metric. I'm out of my league. I'm a labor lawyer. I haven't a clue. I know you have to measure it. Well, it's true. I know you have to measure it. And you have to track it. I was at a meeting, as you might imagine, I've been speaking a lot the last 2 or 3 weeks, mostly with our customers and our hospital and physician partners. But one of the people I spoke with at a seminar a day or two ago talked about, I don't remember the number precisely, and I'm sorry. It was one of the leaders, one of the physician leaders at Kaiser, who said with their new electronic medical record system, they can determine obesity among all their members. They know exactly how many members are obese. And the interesting part of it was that he said through the electronic medical records, they know that it's 36% of their population. Through self-reporting, it's 26%. It struck me so funny, and I was thinking, that really gets to, you need the appropriate metrics. I'd love, if anybody here wants to help us think about that, we'd love to. So
that's great.
I'm going to take one more audience question, maybe two, because I've got a couple people. We had back row. Did you guys still have a question?
It was about, my question was about electronic medical records. And do you think that would improve patient safety with hospitals? And I know Kaiser implemented that system, and it seems to be working from a physician standpoint.
Yeah, the electronic medical records are an important part of any piece of healthcare reform, and it's more the voluntary, non-governmental. Although there could be a governmental system, you could, I suppose, theoretically figure it out for a nation. But it seems to me that private industry can figure this out. What we have to do is figure it out in ways that are non-proprietary, so that a hospital system. We have a couple of pilots going. We have one up in Northern California, one here with Cedars-Sinai in Southern California with our medical record systems. The physician on our team, Dr. Charles Kennedy, is the only health plan representative to President Obama's team looking at this very issue. And what we've learned is that we have a very good system available, and what we need to do is make it workable for the hospital to have interfaces with all the other health plans, because otherwise they've got to have a Health Net, a Blue Shield, an Aetna, a Cigna, whatever, and what they have to have is a system that works for all of us. I'm doing some work right now. In fact, we have been leading the work with the Department of Managed Healthcare and the Department of Insurance and with the California Healthcare Foundation to look at something as simple as a common web portal. I listened to doctors talk to me about what it's like to deal with so many insurance companies, and they describe having to have 20 or 30 different passwords just to get into the system. That ought not be the stuff we compete on. We ought to figure it out once for the industry. I mean, we talked earlier about taking cost out of the system and improving efficiency and eliminating abrasion. What a cool way to do it. Moving to common credentialing for doctors. We all have our own credentialing forms and processes. We make physicians nuts. And you aren't going to come choose Anthem Blue Cross because my form is better than the next. You're going to choose us because we have the best network, the highest quality, the best service, best products, best prices. But we compete on stuff that is just silly. And I've put a call out to the entire industry to say, this is the stuff we can fix all by ourselves. We don't have to wait for regulation or legislation.
Take one more question. Right.
You mentioned the difference between Medicare pays and what private insurance pays, and it seems like when Medicare wants to reduce costs, they just reduce the amount of payout to the physician in the hospitals. Why don't private insurance companies do that as well, or take your price down to what Medicare pays? What risk would there be for Anthem by doing that?
I think there's, if you couldn't hear, the question was when Medicare can't afford to pay or the costs get too high, they just ratchet. This was the question, not my statement. Just for the record. They just ratchet down the reimbursement for physicians and hospitals, and the question was, why don't private insurers do that? I think that practice, whether it's done by the government or done by private industry, is what's at the heart of the healthcare crisis. What we have done for years and years and years and years is simply shift costs. We move costs around in the system. So if the government ratchets down on what they reimburse hospitals and doctors for, and to the point where doctors and hospitals say they can't cover their costs, then those costs just pop up somewhere else as an expense. And what's been happening for years is that everybody fixes their little piece of it and then creates a problem somewhere else in the system. And the reason I'm so intent upon the kind of reform that I've described to you tonight is because it takes cost out of the system. It takes it out entirely. It reduces the cost of healthcare. And so then you can have responsible reimbursement in ways that everybody can make a fair and full living without having to engage in what I think is not the most constructive behavior.
I know we've got lots more questions in the audience, but we do need to be good about finishing on time, and it's been really a wonderful conversation. Let me close with this question. And you've been at Anthem Blue Cross for just a couple of years, but you're obviously in the middle of one of the most interesting times to be in that kind of a role. But, you know, at the end of your career there, whenever that might be, if you could look back on your time there and say, you know, the one most significant thing that I helped influence was, what would that be?
You know, it's so clear to me. I've never been more passionate about anything in my life than what we've talked about here tonight. If I could look back at my career and say, through my seat at Anthem, I was able to bring together the stakeholders across the system of care to solve these critical issues of cost, quality, and safety, so that in fact we could provide affordable access to care across the state and across the nation. I can't think of anything I'd be more proud of.
Wonderful. Well, thank you so much for sharing with us. We really appreciate it.
Thank you very much.
Good. We have a gift for you, and because you love our campus so much, it's actually includes a picture of our campus. So
I didn't even tell you.
So when you can't come see us, you can just put it on your wall in your office, and you can look at it. So thank you so much for being here.
Thank you so much. What a wonderful gift.
It's great.
Thank you all.